right. So I'm looking. Let me see. We have a couple of new people. Tanner Gibson, are you new?
I am.
Welcome aboard.
I am. Thanks for having me.
Sure. Okay. So tell us a little bit about yourself and your favorite movie. And no, I'm just kidding. No, just tell us a little bit about yourself.
Glad to. So I'm an attorney here in Nashville. I'm at Morgan & Morgan now doing personal injury work. Prior to that, I spent 5 years at the public defender's office.
Okay.
So I've got a little bit of a few years of criminal justice work, and interested to see what I can add to the discussion.
Great. All right. Never heard of Morgan & Morgan ever.
We do no advertising. We're very, very small outfit.
It's a very small and there's no connection. Okay. And Councilmember Delishia Porterfield is on. Delishia, can you hear us?
I can, Vice Mayor. Thank you so much.
All right. So Councilmember Porterfield is joining the committee. She's been doing some work on recidivism in the correctional facilities. So she's joining us as well. Let me see if we got it. No, that's it. I'm sliding and there's nobody else sliding across. So Councilmember Porterfield, welcome. Looks like we have a good group today. So let's get right to it. So we had asked last time when we went through the notes, there were a couple of things that people had wanted to talk about. And I think we got at least two people on the call today to help us talk about it. We had talked about, first of all, the behavioral care center out at the new facility. And so Eric Bowder is here to talk about that. And he's on the call. And then we had also talked about the mental health cooperative and about their relationship with the police department and when they get called and those things as well. And Amanda Bracht is here to talk about that. She's the Senior Vice President of Clinical Services. So I figured we'd probably split this call up about 30 minutes each. Now, they also, if you've been watching your emails, we sent you a flyer from the Behavioral Care Center and then a bunch of information with charts from the Mental Health Cooperative. And also, I think Elise was able to send you a lot of program instructions from the Sheriff's Department. So if you haven't seen it, check your email. It was programs that were going on that are available within the Sheriff's Department when somebody is incarcerated in their facility. Okay, so those are all things in your email, but particularly Amanda and Eric, last time, what this committee is focused on is trying to utilize the available data about people going in and out of jails within Davidson County to try to figure out why, in many cases, there's a revolving door. Why do the same people keep being arrested? What are the factors involved in that? And obviously, there's a lot of concern about mental health and substance abuse. And what we're trying to do is figure out what really is happening, and is there a better way to do it? And in the end, does that mean a reallocation of some of the resources to improve on some of this? The question was submitted by Anna Albescu, who is she's in the right-hand corner of my screen. She's now on the call. But that's what we're looking at. And so without much more ado, I think it might make more sense to start with Amanda, because your folks are kind of out in the field and they end up in some cases going to Eric. And so maybe we should start that way. So if everybody's okay, anybody got any questions before we start? All right, Amanda, you're on. Tell us what you know, and then we'll open up for some questions, and then we'll turn to Eric after that.
Okay, great. Well, I appreciate the time to talk about this because I've been working in mental health in Nashville for over 20 years and actually started at the public defender's office many years ago. So I'm really passionate about the topic y'all are looking at. Let me, I sent y'all a lot of information in a PowerPoint, which I'm not going to go over. I'm going to just kind of give you an overview of what we do currently and what we hope to do in the future with some good cooperation from the Metro Police Department and other entities, because we work closely with Eric Bowder in the Sheriff's Office as well. But for those of you who don't know what we do, the Mental Health Cooperative is a non-for-profit. We've been around since 1993, and we were formed out of three main services came together. One was a crisis team. The other was what's called urban care management, or case management at the time, which were really targeted at helping people who lived inside Nashville who had serious and persistent mental illness. And then the third component was a traditional outpatient mental health clinic. Over the years, our services have grown to today. In addition to our Nashville location, we have 10 other locations. We primarily serve a TennCare and uninsured population. So that is our priority population, not only people who are mentally ill, but people who are at poverty or below, not the traditional commercial market. That's just not part of our mission. And one of the key services that we've had from the beginning is what is known as mobile crisis. That's a big catch-all term for crisis services. And mobile crisis is designated by the Department of Mental Health. So the State Department of Mental Health designates crisis teams to cover all counties in Tennessee. My agency, the Mental Health Cooperative, happened to get the contract for Davidson County and have had that, like I said, from the early 90s. Mobile Crisis's mission is to provide assessment and intervention to any individual, regardless of their ability to pay, regardless of where they're originally from. But if they're physically in Davidson County and they're having a behavioral health crisis, that could be anything from the person who's suicidal on the bridge to someone who is psychotic, so they're seeing and hearing things that other people don't see. They suffer from schizophrenia, and they're placing themselves in some sort of risk, of imminent risk. Then the crisis team is charged with providing an assessment. That's typically a face-to-face assessment. During COVID times, it looks a little different. Sometimes it's telephone or televideo, but we do an assessment. And then we have to determine what's the next path for that individual. That path could be, we initiate an involuntary commitment under the state code for the involuntary commitment statutes. And then we have to facilitate hospitalization for them. We have to try to find an available bed. 2, we provide other forms of treatment. And I kind of outlined that in the PowerPoint presentation I sent out. Those other forms of treatment could involve what we call a 23-hour observation and treatment at our crisis treatment center, which is in Metro Center. It could involve a little bit longer stay at a crisis stabilization unit. That's like 2 or 3 day stay, where they get counseling, they get seen by a psychiatrist or nurse practitioner, they're monitored by a nurse, they have group treatment. So we can provide treatment if the individual is voluntary, and then work on a discharge plan back into the community. So we've had that level of services for several years, because in the early days of crisis, it was you provided an assessment, you either put them in the hospital or you sent them to an outpatient appointment that may be several weeks away. And we know for the people that we're seeing, there's a level in between that they need. They often don't need to go into a hospital, but they need another level of service. So that's why we developed those continuum, what we call a continuum of crisis services. Some of you may have seen some of the press and things that have gone on in the last few years around the city. Our crisis treatment center is new. We opened it in 2019, February of 2019. And when we opened it, we immediately saw an uptick in the number of people who walk in for an assessment. These are people who police have not been involved at all. They called our 24/7 crisis line, or they heard about us and they walk into our center and we provide an assessment. That's a majority of the people who we see each month. But then there are also roughly 100 cases per month that the police were the first ones to encounter the individual. So it could be a shopkeeper called 911 because they had a homeless mentally ill person who's refusing to leave their business. Police officers get there, they recognize that the individual has a mental illness. They decide, as opposed to taking the person downtown for booking for some sort of minor offense, to bring them to us. So about 100 cases, like I said, per month. Police bring them, drop them off, we provide treatment and release the officer. Overall, we have seen an uptick year over year in terms of the walk-in volume. We've not seen a significant uptick in the number of police-initiated calls, which we would hope to start seeing more of that since there are more services available. And that's one of the things that we have been in discussion with the new police chief, Chief Drake, to try to look at other ways we can better identify on the front end those individuals who the officer, if the officer identifies a mental health issue, helping the officer get the proper training so they can identify that it's a mental health case. And when the officer has discretion, bring them to us for treatment versus taking them downtown and booking them. And in the PowerPoint, I outlined a couple of different models. What Chief Drake and his team and my team are working on is a co-response model, meaning the officer gets dispatched, they go out with one of our mental health counselors, and we assess on the scene and hopefully divert them into treatment versus an unnecessary incarceration. That's going to take some additional training. We currently do training for Metro PD and have for many years. The new recruits get trained on mental health, as well as in-service training that we do in role-based scenarios where we actually do day-long role plays with officers and try and help them kind of as best we can mirror what it's like when they're dealing with somebody who has a serious emotional crisis that's going on. So our goal is to really help the officers get the training they need to identify these individuals and get them routed to treatment versus incarceration. The other part of what I'm responsible for too is my agency has the contract to provide mental health services at the Davidson County Sheriff's Office facilities. So we also see them when they do get arrested, and we provide mental health treatment to them from that standpoint. Through the increased communication and partnership with Metro PD, and of course we've had for years had a strong relationship with the Davidson County Sheriff's Office, we have a lot of data. So I can look and see that somebody who the crisis team may have seen last month and provided treatment to ended up getting arrested and is in the sheriff's department custody, and my team's treating them over there. I can backtrack and say, oh, wait a minute. How did this person actually get in jail this time? And start looking at their offense. Was it an offense that the officer really had no discretion and they actually had to arrest? Or is it somebody who I need to follow back up with the police department and say, hey, why was there a decision made to arrest this individual this time versus bringing them to the mental health center? That level of communication and cooperation is what I'm hoping will come out of the work with the new administration, the police department, because we have all of the elements in place to be able to share this information appropriately and not violate the rights of these individuals. But we need to do a better job of kind of problem solving when they do end up in the wrong system versus diverting them before they get to the criminal justice system. I hope that's kind of a very high level overview. Like I said, I didn't want to spend time going over those slides. I'm hoping y'all can do that and then have time for questions, because I know it's a lot of information.
No, Amanda, that's really, really good. That's really helpful. Okay, so I'm going to open it up for people to ask questions. What do you want to know from Amanda? Jenny, you're unmuted. Go ahead.
Yeah, first of all, thank you so much for your work, Amanda. You and Adam Graham and your whole team are just exceptional, and the city is lucky to have you. But what I wanted to ask was, it seems to be kind of a hot topic in criminal justice right now to talk about, it's typically phrased as defunding the police. And I read an article today, I think it was featured today, and our police chief was interviewed, and he talked about the model that we've adopted in our city, where the police as well as the mental health cooperative will respond to a crisis situation. And the question was posed to him, well, why do armed officers need to be the first responders to calls for a mental health crisis? And I'm paraphrasing here, but I think his answer was that, sending plainclothes officers into a situation, it provides backup to the mental health cooperative in case a situation escalates towards violence. And I've always thought that the theory behind a joint response is that your team, the mental health professionals, are specialists in providing mental health care to individuals in crisis, and the police are specialists in handling situations with the potential for violence. And the issue is so nuanced. Mm-hmm. And what I mean is, when someone calls the police and that call comes into dispatch reporting an incident, it may just be from a bystander who doesn't have good information. They may be witnessing an incident from a distance. And so there are so many unknowns when responding to a situation. But my question for you is, can you speak to this? I mean, and I don't know if you are personally responding to some of these situations, but would you feel comfortable going into a situation without plainclothes police? Or can you envision, I don't know, any calls? Do you think that this is our future in which it could be feasible that the mental health cooperative goes in without any sort of law enforcement response?
Sure, great question, and I'll do my best to answer. So years ago, I was on the front lines doing those responses, and we did go often without the police. And then over the years, the volume of calls and the types of calls that the police were getting versus what we were getting they get more complicated. So like you said, often it's a bystander who doesn't have a lot of information who calls 911 because they see something taking place. Let's say it's downtown at a business, somebody who's talking, not yelling at people, not making sense. They don't know a lot about the individual. So their natural tendency is to call the police. That's just a natural first response. And in those cases, the police go and because they don't know what they're walking into. It's an unknown. And so there's always going to be those cases, I would say, that come through dispatch where it's an unknown entity that the police they're going to get, no matter what kind of response system we have. Then there's the other calls that, quite frankly, we've seen evolve over the years and I think it's partly due to our city growing at a rapid pace and the impact of drug addiction and a lot of new people who are coming in who we have no history on. So for the most part, people in a mental health crisis are not violent for the most part. And if I know the person who we're getting a call about, because some of them are people who we see frequently, my team and myself included would have no problem going and responding if I know that individual. But if I've got somebody who I've got limited information on or no history on, and somebody's saying that they are threatening themselves or others, there's the potential for a weapon. We hear yelling in the background, which is not uncommon. We're going to want law enforcement there for the safety of the responders and everybody else involved. A lot of the cases that end up with people, unfortunately, being arrested who are mentally ill start with their loved one who's trying to convince them to take medication or something or engage in treatment. There's an argument, it escalates. The family member or support system calls 911 and says, look, my loved one who has schizophrenia is not taking their medication and they're threatening me. Well, that call to that 911 dispatcher is often very chaotic. They hear yelling and screaming in the background. They hear they're threatening me, and it's usually they're threatening me with bodily harm. Again, that's going to be dispatched to a police officer. I'm not going to feel comfortable in many of those circumstances sending my team alone into that situation, even though I know it's a mental health case, but those cases can turn very volatile. Then you add the unknown of alcohol and drug involvement, which quite frankly, in the last 2 years, so many of the cases have involved drug addiction, in addition to mental illness, in addition to trauma. The potential for it to de-escalate and there be some violence goes up. And so for all those reasons, I would love to say that we would never need to co-respond with the police. My take on the co-response is police are there to provide assistance if needed, but the mental health person takes the lead. They're there in case the situation deteriorates or in case we walk into a situation that has all of those elements of heightened emotional response because of family members in conflict. The mental health crisis has been exacerbated by somebody not taking their medication and they're intoxicated at that time. I think, from what we've been seeing, that response can work and it's worked in other cities. I hope that answers your question.
Jenny, are you still there?
Yes, I'm still here. Thank you very much. Yes,
Okay.
Thanks.
All right, next person was Shawn. Shawn, you're next.
Hello, thank you. My question is regarding the training. I know you said there's training. Of course, they go through training. And is there any addition, what's different in the training that they will be undergoing now? And does that include training with that mental health professional as well? One of the things that I was thinking about is the mental health professional takes the lead, of course, but what does that mean? Does the police officer follow the mental health professional's lead? Are they able to make the call to let the police officer know that I have this, there's nothing for you to do? Because one of the things that I worry about is maybe the mental health professional is in control, but the police officer doesn't necessarily think that. And then it escalates before, you know, the mental health professional is able to do whatever he or she needs to do in order to de-escalate the situation. So I'm curious to know about that.
Very good question. I'll start with that first. And I think in addition to training, and I'll talk about that in a second, we have to work with Metro PD to enhance the policies so that it is clear that not just by what we're telling the officer and the mental health clinician, but that it's written down in Metro PD policy that everybody, including my mental health team, is held accountable to. That mental health clinician is the one to take the lead to tell the officer, you know what, we've got this, you can go now, and we're good. We are going to have to spell that out, and there's going to have to be, for lack of a better term, a champion within Metro PD leadership. And I think that they've got some really, you know, good people who are interested in this to help hold them accountable to the policies that we develop regarding that, and that we're following up. And on my side, that I'm picking the right mental health clinicians who can be assertive enough if there is that conflict to say, wait a minute, you know, per what this program is designed to do, I'm the one in charge of the situation. Officers would be in charge if it's obviously getting into a very violent situation, but in terms of what's happening with that person's crisis, that goes to the mental health clinician. As for the training, that's the next piece, is that we need to have what's called crisis intervention team training. And that's 40 hours of intensive training for the officer, where they're not just getting trained on basic mental health and suicide prevention, they're also getting trained on how to interview somebody, or how to help with somebody who has autism, for instance, or somebody who has intellectual disability, refugee communities, because, you know, you have cultural issues that come into play. And you bring in not only mental health experts, but you bring in people who are experts in those other areas, whether it be trauma, dealing with children, autism, and you also bring in people with lived experience. So people who have a mental illness or serious emotional disturbance, who are stable and who have been trained to come in and talk about what it's like when they are in a crisis. So those officers get exposure to somebody who's really living it day to day. And then the other thing is to have accountability. We will need to have a committee that includes people from law enforcement, mental health, but community stakeholders to hold us accountable for outcomes. And we need to be able to track data that we're increasing the number of people, for instance, with mental illness who are coming into a crisis center versus ending up in jail. So there's a lot of components to it, and a lot of work, a lot of detailed work that we have to do to make this successful. The other thing I'll say about the training is, in the last few years, Metro has been really good about saying our officers want more role-based training. They want training where you help us, or we help them understand what it's like for somebody who's suffering from schizophrenia, who's hearing voices, who is off their medication, and who's really in a crisis, how that officer needs to not only physically talk to that person, but how they need to have their physical response can exacerbate the situation. We will have to do more of that for those officers who are part of this co-response model. Does that answer your question?
Shawn,
Yes.
you good?
Thank you.
Okay. Anna, you're next.
Hi, Ms. Bracht. Thank you so much for joining us today. We really appreciate all the work that you do, and also for meeting with us and answering our questions today. I did want to address some concerns. Aren't mental health professionals trained in de-escalating situations, in terms of the patient being violent without police because I know that at least with at least psychiatric patients within our hospitals, they deal with that every day without police, number one. And then number two, how do you intend to deal with police mistrust, especially in regards to communities of color and refugee cultures and communities in which you have mentioned, because there is strong mistrust of the police, especially right now. And three, in light of all of those, do you feel that police presence at these types of calls, I should say, is enough of an escalating factor to, bring a patient to violence, excuse me? And fourth, do you think that it would be a good idea to have police there in the first place and maybe not separate the two? Those are my questions. Sorry.
Yeah,
Try to be succinct. Thank you for your patience.
Sure. No, hopefully I'll remember all of them. So their first question about de-escalation is yes, mental health clinicians are trained in verbal de-escalation. In certain settings, they're also trained in physical restraint. Typically, that's for the physical restraint piece is often if you work in an inpatient unit or like our crisis treatment center, we have trained all of our staff on restraint as a last resort if somebody is threatening, bodily harm to themselves or others. It's easy to do that in a controlled setting, like in a hospital when you know that there's no weapons involved, or in our crisis treatment center when they've been searched and there's no weapons involved. That's a different story when you're responding to the community, when you're on a street corner, when you're in somebody's residence. That's a totally different ballgame. And as a mental health clinician, you're trained to verbally de-escalate, and the situation's going south in somebody's home is to get out and to get out quickly, because you just don't know what you're walking into. So while we are trained in de-escalation, we aren't trained as law enforcement in those scenarios where you're out in a community setting where there's none of the other safety features that there is in a psychiatric hospital. So I hope that answers that question. In regards to the escalating factor, like I said, I've been doing this for 20 years. I have certainly seen where having an officer come into a situation has escalated. I've also seen the opposite, where it's de-escalated, because many times people who are, particularly if they've been dealing with mental health issues for a long time, they can also be distrusting of the mental health system, and sometimes rightfully so, because every time they've seen us, we have had to hospitalize them against their will, which means we've done a commitment form and they get taken to the hospital and they don't want to go there. And the officer approaches and they think, they tell the officer, look, thank you, I'm glad you're here because this woman is trying to, kidnap me and take me to a hospital. And sometimes having that officer present helps some people, not all. So it can be both. And I've certainly seen it over my career where officers escalate and then they can de-escalate. A lot of it depends on the officer. I'm just plain and simple. It has to be the right officers who want to do this. And I think that's where, in terms of the other question that you had about communities that have a lot of distrust for officers, is getting the right officers who develop relationships in those communities. And for instance, in true CIT cities, crisis intervention team cities, the officers who are involved not only respond to a situation when there's a crisis, but they get to know the areas in their city where there may be a higher concentration of people who have a mental health issue. For instance, boarding homes. A lot of people with mental health issues in our city live in boarding homes. And these are homes where 6 to 7 people who have a mental illness live in a home together. A staff member may be there 24/7, or a staff member may only come in and cook their meals. There's a lot of those type of homes in South Nashville, kind of the Antioch corridor. There's some sprinkled in like North Nashville, Hermitage area. And, if we get the right officers and the right team in place, our hope would be those officers who are part of that would develop relationships with those homes. You go in and check in when there's not a crisis, when there's not something volatile going on, so that you develop that trust. And I would certainly see that being a need with some of the other, areas in our city where people are mistrustful of the police. And I'll just tell you real quickly, I think, just 2 weeks ago, we had a situation in our parking lot with a gentleman who was He suffers from schizophrenia. He also was intoxicated. His mother brought him in to get a shot. Despite our best efforts, we couldn't get him in the front door to get a shot. And he escalated, and he was threatening to harm his mother. We had mental health techs there trying to keep him from coming after somebody. And unfortunately, officers had to be called. 2 officers responded. The individual in crisis, he immediately ran to the officer. And we were worried that there was going to be a negative outcome. But the officer, knowing that he was at a mental health place, knowing that we had called him for backup, remained calm and was able to de-escalate that individual and keep him from going after his mother. That's the kind of thing we need to see. We need to see officers who take all the information that they have and help the mental health clinicians when we need it. We don't always need their presence, but when we need it, we need them to be there, but we need them to be there and respond in an appropriate manner, like the 2 officers in this particular case did. You had another question, but I can't remember.
Coming.
Did you get them all? Okay.
Yeah, I think honestly, I think that you kind of covered all of those bases, to be honest. If I should have written them down. If I think of it again, I'll raise my hand. Thank you for your answers. I appreciate it.
No problem.
All right, Jennifer, you're next. There you are.
All right. Okay, so I have a question regarding, you said the 100 on average per month that you all are able to intervene at the beginning of the call. Mm-hmm. Do you have an idea of the demographics or the data of the demographics of those 100 folks? And then another kind of data oriented question is, do you have anything, or just in experience wise, an idea of like what is the precursor to requiring the intervention in the first place, right? Like, is there something we can intervene with beforehand, right? So like, is there a trend with 50% of the calls, if we had just is a really poor word to use, but if we had done this one thing, it might have kept the person from requiring intervention either by your team or have the 911 call be made?
Yeah, great question. At first, on the demographic piece of those calls, I don't know that off the top of my head. I did get that pulled for another committee that was looking at this issue, and I can certainly try to pull that information again and send it over. In regards to that kind of the precursor, it's hard to say. I mean, a lot of times these situations are people who fell through the cracks in terms of the mental health system. They missed an appointment. They got off their medication. If that can be identified sooner and we can engage them, and that's going to take increased outreach by all of the mental health providers in the city to make sure that we're following up with those people who miss appointments, because it's not uncommon for people on particularly people who are mentally ill to miss appointments. And as soon as they're off their medication, you start seeing a decompensation that's pretty quick. So I think having a more robust level of community-based treatment is one thing that we could do. The other thing, though, is that we're seeing an influx of people who we have no history on. They're new to Nashville. They came from other states. They, may have a history of mental illness, and back wherever their home state is, but we don't know them until they end up at the mission or they end up at one of the homeless camps. And so for those people, it's just really hard. It's like, how do we identify them as soon as they come into our city? We often don't identify them until they're in crisis. What I would love to see, though, is more people getting routed to us via their support system, bringing them in. And that's still the majority of people. We see about 700 people a month who are in crisis. Only 100 of those are brought in by the police. So, but still, a vast majority are being brought in by loved ones or themselves. It's a self-referral. But I think it'd be great if we could get more people routed before it gets to a crisis to our resources. And then the last thing I'll say, in terms of comparing like our city to to Memphis. So Memphis is, obviously another large city in our state. They have a crisis intervention team in their police department and have had for 20 something years. And I was recently in contact with one of the leaders who helped develop the system in Memphis. And he said, when I told him our data of about only 100 police initiated calls a month, he said that should be 600 to 700 calls a month. He said in Memphis, the police officers are bringing in a vast, larger percentage than what our city is doing. And that, in his theory, is partly due to we need to have a culture shift that we look for treatment options versus arrest options when officers encounter individuals who are committing really low level minor misdemeanors like obstructing a passageway or trespassing in one of the businesses downtown. He said, the advantage we have in Nashville is that we have a more robust level of outpatient care than they do in Memphis, but we need to have a culture shift to where people are diverted into the crisis system and the outpatient treatment at a higher rate. Hope that made sense.
Yeah, it did. One of my background is mental health and social work, and so I can really understand the de-escalation and coming into a situation differently than how a police officer comes into a situation.
Mm-hmm.
And so from my perspective and the community that I live in, like it will take a lot for me to reach out to MNPD because I don't want any of my neighbors to die. Right. So when we talk about mistrust, like it's a very real thing. And so that number probably should be higher, but I guarantee that people are not making the phone call because I don't want to be responsible for someone dying because I didn't know of another option. Right. Like I'm not going to bear that. I don't want to bear that burden or put that on my neighbors' families to have them have to be traumatized by that too. So
Sure.
Definitely a huge trust barrier to overcome. And that number, I agree, like, well, we all agree, that's why we're here today. That should be higher so people can get help.
Okay.
So I appreciate it. Thanks.
Hey, hold on, whoop, there I'm back. So we have, once again, we have a hard stop because they scheduled a budget meeting at 6 o'clock. So Eric, we may have to ask you to come back. That doesn't mean that you don't have to leave right now. You can stay and listen, but I don't think we're going to be able to even get to you yet. It's by 6 o'clock. So if you have, and I really appreciate you being on, if you need to take off, fine. If you want to stay on, but we may have to ask you back to the next meeting, which is in 2 weeks. Okay. Is that okay? All right. Because I've got a whole line of questions, and obviously we like Amanda better than we like you. So there you go. Okay. So thank you, Amanda. We have a hard stop at 6, so we'll keep going. So Councilmember Porterfield, you're next.
Thank you so much, Vice Mayor. And this has just been a really robust conversation. I really appreciate everyone's perspective. This is an area that I'm really passionate about, so I'm really enjoying this conversation. I've worked with some elected officials across the country on how we can better the relations between our police departments and what we can do to look at the responses when people are in mental health crisis. So, I've talked to Chief Drake, and I just want to commend Chief Drake and Amanda. I mean, this is wonderful. Like a co-response really is cutting edge policing at this time. Like I know that there are kind of those two schools of thought. The one school of thought was, to not have the police response and to only have the mental health professionals respond. And then you have the school of thought of having that co-response. But the fact that Nashville is moving to the co-response model in and of itself is a huge, huge accomplishment. So thank you all so much for doing that. And I appreciate Chief Drake's willingness. I do have a few links to share with you all. I can drop them in the chat if that's okay with you, Vice Mayor, but it's on some case studies of what some people are doing around the country when they're looking at the mental health responses and the co-response with the organization that I've done some work with and actually helped to write one of the studies that that I can share the link with you all if you all want to get more information about it. And I wanted to just kind of say to Jennifer's response, I have personally been in the situation of having a family member in crisis and really trying to navigate that situation of, calling the police, and the police is saying to call mental health co-op, calling mental health co-op, and they say you have to call the police, and just really being stuck in the cycle of, each entity is telling me to call the other entity. And I almost went into a panic attack because I was so afraid to call MMPD, even though I knew that the person would not cause harm to anyone else. My fear is that they would accidentally cause harm to themselves. So I felt that a mental health provider was needed and a police officer was not needed, but because both had to be there, eventually they did come. And it was, for me, it was, I actually went and met them there. And it was a way better experience than I would have ever imagined. And I think to Amanda's point, it really depends on which officers are responding. So the officers that were responding were gracious and they were calming and they were able to get the person calm enough to voluntarily go to the hospital for the evaluation so that they could, get the help that they needed and get back on their medication and things of that nature. So I guess to pull it all together, my question in this is, are we considering possibly having a dedicated unit for the co-response so that these individuals are having that additional training? And I apologize, I had to step away for just one moment when you were talking about the amount of training. So my apologies, I wasn't sure if that was for all of the individuals or if there was a dedicated unit that would specialize in this. And my thought would be, if Nashville is really, kind of starting with this co-response model, I think once enough data is collected, a year, 2 years down the line, I think, we all would be open to having additional conversations to say, hey, this has worked really well. We've not had to use the police in any of these instances. Let's look at, phasing the police out. Or, hey, we've had to use the police in these instances. Let's figure out a model of when we continue to use the police or when we think that it's safe for the individuals to go. So I can't speak on behalf of Chief Drake or MMPD because obviously that's not my wheelhouse, but I will say that he's been very responsive and very open to having these conversations about reimagining what public safety looks like and making sure that everyone can feel safe in their community.
Yes, I appreciate you saying that, and I sorry about your experience because unfortunately I see it all too often where you call and you get bounced between the two systems, and I think that's why a co-response model is so needed in our city. Chief Drake, in his short tenure as chief, has been incredibly communicative with us about saying we've got to make a change and I'm committed to this. It's my understanding that they want to start with a pilot project that would have dedicated officers who want to do this instead of training the entire police force. The previous administration's thought was, well, we train the entire police force on mental health. Well, if you train everybody, you don't have any specialists and you don't have people who really want to be part of these types of calls. And we've really advocated for a long time to say you need to have a special unit. And so I believe, based on, I don't want to speak for Chief Drake, but based on my last conversation with him, that is the direction that he and his team are moving in. They also are looking for, there's some grants that are going to be released in the spring, some federal grants that could help with that, help offset some of the cost of the training, as well as, pulling officers from regular duties to do this. In addition to helping, my agency is going to need some additional resources to pull this off in the right way. So they've started looking at those grants and they've started meeting with us about that because we feel strongly it needs to be a dedicated team. It needs to be people who can develop relationships with the mental health providers so that there's an element of trust. Because if I go out on a call with an officer I've never dealt with before and I'm telling him I want to take the lead, there's going to be a little bit of a power struggle. But if I've worked with that officer, he knows I'm part of that team, and I know that he or she's part of the same team, we're going to approach that case much better, and you're not going to have that same power struggle. So I think that's incredibly important. I also think that we, to your point of like, let's try this out, let's look at our data. If we find that we really weren't needing officers a lot, or if we can identify cases earlier at the dispatch level, that's one thing we haven't talked about is training for dispatch to say, you know what, that call really doesn't need the police officer present. That just needs a mental health presence. We can carve out, in my perfect world, in a few years from now, we'll be talking about responses where it didn't involve Metro PD. And then there'll be a small group of cases that will still have to involve Metro Police, but in the vast majority might have other resources. But we've got a lot of work to do before we get there, in my opinion.
Okay. All right. I'm watching the time carefully. Morgan, you're next.
Thank you so much. You're sort of already touching on this, but to keep going down this path, I'm curious about what does the ideal relationship look like between your mental health co-op and the police department, and what are the biggest obstacles you see right now in reaching that ideal goal? If you had to boil it down, is it funds? Is it lack of interested police officers? Is it lack of police officers in general? Is it money? Is it time? You know, what would you say is the biggest obstacle to those goals?
Wow, that's a good question. I think right now, and we've made progress in this area, but it's identifying who's going to be the point person on the Metro PD side to help get this launched from a champion who's really going to own it from Metro PD side. We've already dedicated a staff member, and have for the last 2 years, I have somebody who's dedicated as our law enforcement liaison. And that is his job, is to build relationships with Metro PD and to be the one to deal with any issues, follow up on any issues we may have had or they may have had. And that's worked out well. He's developed good rapport with the patrol officers, but we need to carry that further and have policy development that I mentioned earlier, accountability structures that we're holding true to those policies. And then funding. I mean, to be perfectly honest, funding is an issue. I can't speak for Metro PD. I can speak for our agency. This fiscal year, we're operating about $1 million in our crisis division because the cost for doing this care continues to go up. The cost for nurses and techs continues to go up, but the funding is flat. It's largely grant funded and it's flat. So if one of my big worries is if we are successful and officers start bringing us that 600 to 700 people a month, in addition to who we have been treating, I'm not going to have enough resources to man that. So that is probably my single biggest worry right now. I think we finally got the right people at the table and are getting the right people at the table for Metro PD and our side. But if we're really good at what we plan to do, we're going to have a shortfall over here in terms of the ability to treat the people we're identifying.
Hey, Amanda, you froze right at the most important part of how much money you were. So it sounded like $1 million and then you froze. So what were you saying?
It's just under $1 million. It's 900 and something thousand shortfall for this fiscal year.
And that's so, in terms of this fiscal year, you're based upon your operating budget, you're running about $1 million short. What's your overall operating budget?
Oh gosh, I was just looking at that. I can get that to you. I blanked on that right now, but I can tell, and just so y'all know, full transparency, our funding stream. Majority of our funding comes from the Department of Mental Health. It's a flat grant amount to operate these services. Then we do, for those individuals who we treat who have TennCare, we can bill TennCare a rate for the services. And then we get $400,000 for the city. That's been new, about $400,000 we started getting about 3 or 4 years ago now. And that's it. That's what we do. So we get that level of funding regardless of whether we serve 80% who are uninsured or 20% of who are uninsured. And right now, and for the last couple of years, 70% of the people we see are uninsured. So the only funding we get are the dollars we get for the, the flat grant amount we get from the city and the grant we get from the Department of Mental Health.
Okay.
I mean, unfortunate, we are successful non-for-profit, so there are other lines of our business that, we're able to keep the doors open with that loss this year, but our board of directors is not going to let us do that year over year. They've made that very clear.
All right. Tanner, you're next.
Thank you so much, Amanda, for doing this. I had a question about sort of the quality of care that you're able to provide on the outside versus on the inside. You said earlier that you have the contract to provide mental health services in the jails, DCSO facilities. I think before the BCC was built, the jail was probably the largest provider of mental health services in the city, which is a tragedy. Mm-hmm. But do you see a difference in level of service or quality of service or outcomes for, incarcerated people in the jails versus people who are able to be diverted to programs outside of the jail?
Great question. I will concur that the jail, DCSO is, they have on any given day about 300 inmates who are on psychotropic meds. That's more people than there are beds at Middle Tennessee Mental Health Institute. So our regional mental health institution that covers an entire middle region, not just Davidson County. So DCSO is the largest quasi-inpatient psych unit in our city. The other thing I will say is that we became the psychiatric provider there in 2005 and to this day, and we have tripled the number of mental health staff that we have in our jail services since 2005. I would have loved to have been able to decrease the mental health staffing, but we have to keep upping it because of the needs of people coming in the jail. Now, I will say, I think the reason why we've been able to increase is we've been able to show that there's a need, but also we've had a commitment from the Sheriff's Administration and the Metro Health Department to say mental health is going to be a priority for our inmates who are coming in. And so in a jail setting, mental health consists of you get assessed by a master's level clinician, a treatment plan is developed, and you see a psychiatrist or nurse practitioner for medication. And then that master's level person will follow up and make sure you're taking your medication. You don't get in-depth counseling. You don't get, certainly right now, you don't get group counseling because it's in a jail setting. Whereas on the outpatient side, you have a little bit more flexibility. We can, you can have more individual counseling sessions because many of these people, medication's not alone going to fix it. It's trauma. It's significant trauma. It's needing to get their basic needs met. They're worried about where their housing is going to be. They're worried about how they're going to get from point A to point B in our city. How to navigate the bus system. They need those basic tangibles, which when they're in the jail setting, we don't really have time to work on those things for that person as they're coming out the door. It's basically, here's your medication. We want to make sure you're taking it. Good job. And then we move on to the next. So there's definitely a difference and there's a limitation of what we can do in the jail. But this is probably, I will say DCSO mental health staffing is probably one of the most robust I have seen. I think it's definitely the most robust in the state of Tennessee. And that the sheriff should be commended for being a strong advocate for that.
Tanner, good?
Thank you.
Okay. All right. So we've got about 4 minutes left. And there was good questions in the box. Amanda, we may want you to come back. If you want to, you can come back in 2 weeks, or we may have you come back because the information is vital to what this group is looking at. So let me ask you the one question that I think that Shawn asked in the chat box early, the 40 hours of training at the beginning for police officers. The question is, okay, so if that's at the beginning, ongoing training, I know that the police get ongoing training throughout the year. What about mental health training? Shawn, is that basically your question? And the question would be how much training do they get?
It's typically just an hour in service once a year, once after they've gone through the academy. And so it definitely, I think that needs to be beefed up and certainly that's why I think this co-response model is definitely needed. A specialized team would get more advanced training. The SWAT negotiator team, for instance, they have a really robust team of great hostage negotiators.
Co-response model for Nashville.
They get a lot of in-service training, which they ask us to do a lot of. They get multiple hours I think it's every month or every other month. And that's what I would like to see similar for this specialized unit, is that it's monthly kind of refreshers.
All right, and let me follow up because that was such a good answer that you've got 2 minutes left on this question, which just follows up. It's like, for the requirement for officers who want to be part of that, if that special unit, what is the requirement to be in if they create this special unit? Well, and they've got some folks in there. Is it people wanting to be on that, or are there certain requirements that you have to get on that team?
You know, that's a great question. We have not developed that yet, but other similar cities, it's not only they want to, but there's a panel of people who interview them. And that panel is other officers, officers who maybe have an expertise in the area, as well as mental health input. And I would advocate we need to do that. It shouldn't just be because they want to. That should be one factor, but we need to make sure we've got officers who are doing it for the right reasons and have the right skills and ability to do this.
Okay. And I think that's what Shawn was looking for. All right. So we had a couple more. One was mental health services to the police. So, you know, if they're having a difficult time providing mental health service, do you know anything about that?
Yeah, they have a psychological services. It's called, I forgot what it stands for. PASS is their acronym, where they have counselors who officers can go see. That it's part of the police department, but it's all kept confidential, and they have pretty robust services there.
Okay, and Councilmember Porterfield just sent you a Budget 101 series with the Metro Police Department. Okay, so we're out of time. Amanda, thank you so much. Eric, thank you for hanging in there with us. We meet again in 2 weeks at the same time. If you don't mind Eric coming back. Amanda, you're welcome to come back. You're welcome to listen to all this. And if you don't come back, we may come find you and bring you back, because this is really important. This is sort of what this group is looking for. And so I know there was one question about estimates of moving 600 people or diverting them. We'll have to take a look at that one. And particularly on your budget, we're going to have to look at. And that's one of the things that this group is looking at. Okay.
Thank you for your time, and I'd be happy to participate again. And if y'all have questions, my information is on that slide deck, and I'd be happy to answer questions.
Okay. All right. Thanks, everybody. Really good discussion. 2 weeks. Go out and play in the snow, but don't do anything real bad. Okay. And we're signing off, so budget can then start their stuff. Amanda, Eric, again, thank you. Good to see everybody. Okay. Everybody be safe.